Hello, everybody. You're very welcome. I'm Gary McMichael. I'm the Chief Executive of ASCERT. You're very welcome to today's webinar. ASCERT is a charity based in Northern Ireland that's been delivering substance use services for the last 25 years. And as part of marking that milestone this year, we're organising a series of webinars, and this is the first, focusing on topical issues. So this one is around synthetic opioids and a focus on nitazenes. This morning, we've got a great lineup of contributors from across the UK and Ireland to give us their perspectives and help us consider what this means for our approach in Northern Ireland. So the webinar is going to last for 2 hours without a break. Just for housekeeping information, the chat function is disabled. We do have a Q&A function. If you have questions for speakers, please write them in the Q&A at any time, and they will be answered during the Q&A session. We will have a panel discussion at approximately 11:30 after the different contributions, and your questions will be answered there. Also, the webinar is being recorded, and the recording of this webinar will be made available to you after today. So we've a great lineup today. We've got Steve Rolls, Senior Policy Analyst from Transform Drug Policy Foundation, Nikki Colleen, Emerging Drugs Trends Project Lead from the HSE in Ireland. We have Kevin Bailey, the Regional Lead for Drugs and Alcohol in the Public Health Agency in Northern Ireland. And we've got contributions from Derek McParland from the same community, Ian Buff Cameron from Extern, and Tim McQuaid from DePaul, Ireland, on behalf of Frontline Services to give us their perspective. And then we'll have a panel discussion, which will be chaired by Professor Anne Campbell from Queen's University Belfast. So thank you for all the speakers for agreeing to attend today. So let's get things kicked off, and I will hand over to Steve Rolls. Steve.
Thank you, Gary. Hope everyone can hear me. My name's Steve Rolls. I'm the Senior Policy Analyst for the Transform Drug Policy Foundation, which is based in the UK, but we engage in policy debates internationally. We're focused on drug policy and law reform, and we do policy analysis and advocacy. So please check out our website, transformdrugs.org, if you want to find out more. So I'm going to share screen. I've got a PowerPoint for which, well, I would apologize, but it's probably preferable to looking at my face. Hang on a moment. Share. I hope you can see that. Gary, can you nod if you can see that? Right, got some other. Okay, so I'm going to talk about the synthetic opioid threat, focus on nitazenes, but I'm going to speak about it a little more broadly because I think that's important. Where we're up to, what's going on, and what we need to do from the Transform perspective. And I appreciate there are other perspectives on this. I think the first thing to do is just to acknowledge that we are in a period of rapid change within the illegal opioid market. There are lots of things going on in the opioid market. I want to talk about the Afghanistan opium ban and possible impacts of that in particular, but it's not the only variable in play. Clearly, opioid markets are changing all over the world. North America is an interesting example that we'll come back to. And they're not impacted by the the opium ban in Afghanistan at all, because most of their heroin and other synthetic opioids comes from Mexico. So Afghanistan isn't the only variable in play, but I think it's a critical one for the UK and Europe, because 95% of, according to estimates, 95% of heroin that reaches the UK has historically come from Afghanistan. Now, in April 2022, the Taliban, having regained power, announced a ban on opium production. And by June 2023, approximately 95% reduction in the opium harvest had been achieved. So they announced this ban and it basically worked. And that creates a legitimate and probable threat that the heroin supply from Afghanistan, the heroin pipeline, will effectively be completely choked off. This has actually happened before, just after the Allied invasion in 2001, following 9/11. But sorry, just before that, there was actually an opium ban announced by the Taliban then, but it didn't last, partly because of the Allied invasion. But we do have some precedent for this. But the question mark really was, will that ban hold? Will it continue for more than one planting season? And the updates from the planting season of autumn 2023 is that the ban has largely held. So we've now had 2 planting seasons during which opium production has effectively ceased or been dramatically reduced within Afghanistan. And you can see some of these graphs, some of this satellite photography on the left. The pink dots are opium production, and by 2023, it effectively stopped. Now, there are open questions about both how long the opium ban will continue for, the size of stockpiles that might be able to bridge the gap, because there have been bumper harvests for a series of years. Opium stores very well. It can be kept for 10 years or more. There are significant stockpiles of opium within Afghanistan, and it may well be that some of these are now being released to meet demand in the absence of actual production. But there are a lot of question marks on this. So we are moving into really quite an unpredictable phase in terms of Afghanistan opium and heroin production. Will the opium ban be maintained? We don't know, but at the moment it looks like it might well be. There are various political and economic variables in Afghanistan that are quite hard to read. The Taliban has historically derived significant income from the opium industry, and they may be reluctant to forego that. On the other hand, if they don't reduce opium production, they may not be welcomed back into the international fold and able to access aid, for example, from various multilateral or national forums. So it's quite difficult to know what's going on. The graph, the lower graph shows opium prices from 1997 to 2023. And if you look at the right side of that graph, you can see that opium prices since September 2021, particularly in 2022 and 2023, have been going up rapidly, but are very volatile. So the rising opium prices does seem to suggest that there is a constriction on supply, basic supply and demand economics, and it's unclear. It may be the volatility reflects release of stockpiles. Some people may be holding on to their stockpiles, waiting for the prices to go up before they release them. It's difficult to know, but the volatility suggests a constriction in supply. And I think we have to assume that supply from Afghanistan will continue to be heavily restricted for the foreseeable future. But obviously, we don't know quite how it's going to play out. So what are the scenarios in terms of Afghanistan production? It may be that the ban fails or is lifted and heroin production is restored, and stockpiles that exist will be able to bridge the gap, and there won't be any particular impacts on heroin supply to the UK. A second option is that the ban holds in Afghanistan, but production moves to other traditional opium production and heroin production regions, such as the Golden Triangle. A third option is that the ban holds, production elsewhere is not able to meet the demand quickly enough, because obviously it requires a significant expansion of opium production and heroin processing, which takes some time. And the shortfall in demand is met by synthetic opioids in European markets in the interim. I think personally the most likely scenario is a combination of these effects. So we'll see The ban will hold, but will to a lesser extent. There will be some production in Afghanistan. It will rise, but not to previous levels or anything like them. The Taliban's control within Afghanistan is uneven. Some regions they have very good, strong control. Other regions not so much. It may be that there'll be displacement of opium production within Afghanistan, dictated by local political variables. Production is already rising in some of these other regions, but I think it's unlikely that production will rise fast enough to meet the shortfall from following the Afghanistan ban. The Golden Triangle is now the leading opium production region for supply to the EU already. But again, I don't think that will be able to meet supply fast enough. And I think there is a grim inevitability that some of the demand in Europe for opioids will be met by increasing penetration displacement within that market by synthetic opioids. That includes nitazenes. It includes the nitazenes group, and it's important to remember that nitazenes isn't a drug. It's a family of drugs that vary in their potency by an enormous amount. So some may be 10 times as strong as morphine. Some are 1,000 times stronger than morphine. It's similar to the fentanyl group, of which there are, I think, 35 or 40 have already been identified, various fentanyl analogs. A couple of them are legit, like remifentanil and carfentanil, but there's about 35 other ones that, again, vary in potency enormously. Some of them are 10,000 times more potent than morphine. Some of them are 100 times more potent than morphine, like fentanyl itself. So we have this enormous kind of zoo of synthetic opioids. It's not just a single entity. We're talking here about nitazenes and fentanyls. There are other synthetic opioids that exist, and there are other ones that are likely to be created. The situation is likely to get more confusing, more messy, and feature more hard to identify synthetic opioids in the future. And it's also not just opioids. We're also talking about synthetic benzodiazepines, which can fulfill a similar gap in the market, and I think maybe we'll come back to that. Finally, I'd just like to mention on the Afghanistan thing, there are also economic impacts of this within Afghanistan. Afghanistan is a very poor country. A lot of people migrate into illegal markets and illegal opium production as a form of economic survival. It's very much a survival economy. It's one of the few products that they can actually get some money off. It earns significantly more money than traditional products like wheat. And the ban is having serious effects on in terms of poverty and hardship for communities across Afghanistan. So I think it's important to remember that our policy in Europe has real human impact in Afghanistan as well. It's not just a domestic problem for us. In terms of the impacts of all this on the UK market, there's an open question. I think some of the other speakers, I'm sure, will come back to this in terms of whether the impacts are already being felt. To what extent is the market already mutating, and to what extent is this driven by Afghanistan? It's obviously quite hard to know. What we do know is that demand for opioids and the effects of opioids as a group of drugs remains. We know the profile of opioid use is significantly problematic users, people in situations of economic and social marginalization. People are kind of self-medicating for physical or emotional pain and trauma. That demand is not going anywhere. And I think we need to be realistic that if those people don't have steady supplies of opioids, reliable supplies of opioids, whether that's legal or illegal, the market will adapt to meet that demand in other ways. There is money to be made there, and the illegal market has been brutally effective, relentlessly effective, and flexible to adapt to meet that demand and exploit that profit opportunity. So while that demand remains, if the heroin supply continues to dry up, it will be displaced significantly by synthetic opioids. I've also mentioned benzos. I think we need also to mention xylazine, which is a veterinary drug which sort of potentiates the effects of opioids in humans, and possibly other drugs as well that we haven't identified yet or haven't arrived yet. But as I said, it's going to get worse. It's going to get messier. The illegal market doesn't care about our surveillance and forensics. The menu of drugs that will enter the market to meet this continuing demand in the absence of heroin is only going to get bigger. There's already some police and anecdotal reports of falling heroin purity. Heroin purity is apparently down to 16% in Scotland. It may well be that the falling heroin purity in Scotland, that's got nothing to do with Afghanistan, it may be other factors, has already been driving rising levels of synthetic benzodiazepine use in Scotland, which have been associated with 60 to 70% of overdose deaths in Scotland. In the UK, we now have apparently there's been about 65 nitazene deaths, I think, in the last 6 months. In the most recent report I've seen, that's about 2 a week. The numbers may be higher. It may be that some synthetic opioid deaths are not being identified forensics because forensics isn't testing for them yet. The number of seizures of nitazenes has gone up 5-fold in the last 2 years. And in November 2023, the Met seized 150,000 nitazene tablets, which suggests to me we're seeing sort of major moves by organized crime groups into the nitazene market, and a kind of upscaling on industrialization of that, which I think should be ringing alarm bells. What are the implications? Well, we know what the implications of synthetic opioids penetrating heroin markets are, because we've seen it play out over the last 5 to 10 years in the US and Canada. Fentanyl adulteration began adulterating the heroin market, and in many places, as that fentanyl has now significantly displaced heroin supply. In places like British Columbia, it's almost impossible to get heroin now. It's almost a completely fentanyl-dominated market. And once that cat is out of the bag, it's very difficult to put back in, both in terms of the supply infrastructure, but also in terms of user behaviors. So even though initially it was people wanted heroin but could only get fentanyl or fentanyl adulterated heroin, we are now seeing significantly fentanyl-seeking behavior, also combined with polydrug use. So fentanyl is being used with other drugs, either deliberately or inadvertently. Fentanyl has been mixed with xylazine. Fentanyl has been mixed with and sold mixed with benzodiazepines. Fentanyl is being widely used with synthetic stimulants such as methamphetamine and other synthetic cathinones. So like I say, the situation has got very messy. It's not just about nitazenes. It's about this broad menu of synthetic opioids and other drugs that have progressively displaced the heroin markets in the US and led to this absolute catastrophe. So you can see 2010, there was 21,000 opioid deaths. 2021, 80,000. So a 4-fold increase over a 10-year period, and a doubling in the last 5 years alone. Now, if you imagine the UK is somewhere at the foothills of that horrifying graph around 2013-14, we could easily see a doubling or tripling or quadrupling of opioid-related deaths in a matter of years. I don't think this is a precise model of the UK experience. There's obviously other factors there, but I think that gives some scale of the threat that we are facing. So are we prepared for this threat? We don't know what the risk of this happening is. Is it a 10% risk of synthetic opioids displacing heroin? Is it a 90% risk? I would argue that even if it's a 10% risk, given the scale of the potential catastrophe, we need to be taking it extremely seriously. My sense is that there is a grim inevitability here, and a 90% risk assessment is much more realistic. I think it is inevitable. I think the cat is out of the bag. I think organized crime groups are looking at this market and thinking, Why would we continue to have to grow opium in Afghanistan, process it, transport it halfway across the world, when we can manufacture synthetic opioids wherever we like? We're not subject to the whims of Afghan production and politics. We don't have to transport stuff all over the world. And why would we bring 50 kilos of heroin when we can bring a matchbox of nitazenes or carfentanil, which is much easier to transport, it's much more profitable, and we don't care whether people die? So there is a grim inevitability here. It is happening, and we need to be prepared for it. I think we are looking down the barrel of an imminent public health emergency. I think the US shows exactly what can happen and what is likely to happen, and it requires an urgent preparedness strategy that we currently do not have. I don't know whether there are people here from the UK government, but the planning that we've seen, and we have been in contact with the government, we've contacted ministers, we've contacted opposite shadow ministers, we've contacted the departments, and what they have been reporting back to us seems to us to be woefully insufficient. Essentially, it's a restatement of existing strategy. They've set up some task forces and things. It's a restatement of existing strategy with a bit more surveillance and some tough talking on enforcement. What we need is a national harm reduction strategy that is unaligned from some of the current politics and ideology which dominates the drug policy debate in the UK at the moment. Unfortunately, even more so with an upcoming election, there's a kind of ideological hostility with the UK government to harm reduction, and a big emphasis on recovery, prevention, and enforcement, none of which are relevant to the threat to this vulnerable population of synthetic opioids. What we need is an emergency harm reduction response that needs new money and political commitment, neither of which are currently there. And there is a real risk, I think there is a real risk that there will only be action when this crisis is already upon us and the bodies are starting to pile up. And that is already a trend that we are already seeing. And we already have a drug death crisis, but it could be about to get a lot worse. Hang on a sec, sorry. In terms of what we need, an emergency harm reduction plan, yes, we do need better surveillance and monitoring. Sorry, that was my 20-minute alarm. I'll wrap up, I'll stop ranting in a minute. We do need better surveillance and monitoring, things like seizures and forensics, to allow for local rapid responses in the short term, although I think this is going to be not a local response issue, but a national issue very soon. We need drug checking services rolled out nationally. People need to be able to check their drugs to see whether they contain synthetic opioids and act accordingly. At the very minimum, we need to make nitazene and fentanyl testing strips widely available. We need vastly better access to naloxone. We need to be spraying it around all over the place for free. We also need to be educating people how to use naloxone in the concept of synthetics, how many doses, how to use it, likely effects, and so on. So there's an education piece there as well as an availability piece. We need supervised drug consumption facilities rolled out nationally with considerable urgency. There's one opening in Glasgow this year, hopefully. We need 50 or 100 to be available, now, immediately. I know it's a highly a politically contentious issue, supervised consumption, but we know they work, and we know they work specifically for threats such as overdose related to synthetic opioids. We also need to explore enhanced harm reduction housing, so tolerated and semi-supervised use. So that's a sort of semi-supervised drug consumption facilities built into the housing for vulnerable homeless people who are using drugs. And we need to explore innovative prescribing, lower threshold access to heroin-assisted treatment. We need to explore options for low threshold prescribing of hydromorphone and possibly some other opioids. And we need to revisit the possibility of prescribing benzodiazepines. Finally, in terms of political strategy, how do we make that happen? Because unfortunately, this is all very politicized. Drugs policy always is. I think that the public health field needs to be speaking with a collective voice. We need to gather people, experts from the addictions field and other relevant fields, harm reduction and so on, and people with lived and living experience. And I think we need to be engaging the recovery community and recovery voices as well. We don't want this to become a kind of polarized harm reduction versus recovery, tedious type debate. This is about saving lives now. It's an emergency and we need to be dealing with it. We need to lay out what's needed, when it needs to happen and how much it will cost. We need to use the US catastrophe to hammer home the urgency, perhaps involving bringing US voices to bear on the UK debates. We need to avoid the kind of partisan polarization that we've seen with some of these debates. And we need to be absolutely clear that there is no enforcement solution to this problem. Knee-jerk reactions historically in drug crises have tended to err towards enforcement solutions. Enforcement is what has created this problem significantly in the first instance by creating these perverse economic incentives to bring synthetic opioids to the market. There is no enforcement solution. Enforcement will only make this situation worse. I can talk more about that. And just my final comment, we need to act now before it's too late. We don't want this to be a I told you so type scenario. We can prevent this catastrophe. We don't want to be reacting to a catastrophe after it's already happened. We need to be putting in place preparedness, emergency preparedness now to save lives. We don't want thousands of deaths to be the spur to change in a year or two's time. And I'll end there. Apologies for that being so rapid and a bit ranty, but I had a lot to get through, and I'm happy to answer questions now or in the Q&A session. Thanks very much.
Okay, thanks very much, Steve. Great presentation. Really provides a very strong context for us in terms of the rest of the contributions and the discussion later on. There's some questions appearing within the Q&A. You can answer, respond to some of those by text through the Q&A, but we'll hold open questions until the Q&A session itself. Okay, so our next speaker is Nikki. If I could just hand over to you.
Thank you so much, Gary, and thank you, Steve, for that informative presentation. I'll share my screen now, and again, if my slides aren't moving, please just let me know. Is that okay for everyone? Yeah. So today I'm going to be covering the situation that we've seen since November in Ireland and some of the work that we've done. And my apologies for anyone who attended the HSE's webinar last week. There will be some overlap. So I work for the Health Service Executive, which is the public health agency in Ireland. And my job within the HSE is to look at what call emerging trends. So for the past few years, my role has been focusing on preparedness, I suppose, in a way, with a specific focus on some of the user groups that we wouldn't traditionally engage with. So specifically looking at use in social settings, and other groups who may not be attending our services, which are generally aimed at people with dependencies. Despite that, I would have a role to link with a number of different service providers and agencies. So I suppose in the lead up to the Nitazene outbreak, we had some foundation work done. So we'd developed an established relationship across networks who knew to contact us if something were to change. And I suppose that really did help us in our response. So I suppose what we are looking at and what we need to focus on is increased awareness, preparedness, better responses. And we do know this will reduce harm across all of our user groups. We are concerned, and I will highlight it again, that drug market changes can impact all user groups, and there's a number of trends that we are concerned about at the moment, including Nitazenes. So in terms of I suppose, a significant change for us, I suppose it was the development of our emerging trends and drug tracking report. The work began in 2019 and we published it in 2021. And while this report focused specifically on nightlife populations, it highlights key areas such as how drug market changes can impact on the end user group with the report, we did highlight PMA at the time, and PMMA, and how that impacted the MDMA using community. And we made a number of recommendations, and we called for increased drug monitoring, improvements in emerging trends, responses. We highlighted the importance of new monitoring tools, particularly the role of drug checking and expansion of drug checking services. So for the past few years, we've been making some attempts in terms of improving analysis through syringe analysis, hospital monitoring, trying to establish wastewater drug checking, and improving our research through web surveys. We had been watching, I suppose, the international situation, and we were quite aware that while Europe wasn't impacted in the same extent in terms of fentanyl, we were very conscious that nitazenes may begin to be an issue, particularly based on what we were seeing throughout the UK and wider Europe. So nitazenes themselves aren't new drugs. They have been around for some time, and were developed in the 1950s, but were never brought to market due to their potency and concerns for overdose risks as well as dependency. What we did see was, I suppose, the initial changes around 2019 in the form of these substances beginning to appear in different formats, and we were very closely watching what was happening in the UK and Scotland. Of particular concern, and we weren't sure what direction the Irish market was going to take, was the falsified or counterfeit medications, so oxycodone and falsified tablets, which were starting to appear. In terms of the Irish situation, as I said, we were aware something was going to change, and as Steve highlighted, there are changes coming down the line. And this is something that has many question marks. As Steve highlighted, it could take a number of different pathways, but I suppose what we started to see and what we think we saw from November onwards is market research on the Irish market. So on, I suppose, the 9th of November, I suppose things did very significantly change for us. We were very quickly informed that there was overdoses occurring in the city, and these were very different. So the initial report came from homeless service providers, who had said that these overdoses were very complex to manage. They required what they felt was additional doses of naloxone, and there was something significantly different here. So this really was the first signal of change for us, and we took it very seriously and responded very fast to it. So what we did at this point, and just to highlight the timeline, I suppose this timeline here shows how quickly and how suddenly they can emerge. So it has been a significant lesson to us that these batches can move, and we saw it move through Dublin very quickly and impact a number of people very quickly. So the timeline of events, I suppose, was very early on the Thursday the 9th, we were informed. And we decided by lunchtime on the Thursday, based on the anecdotal feedback that we started collating from ambulance services and service providers, that we had to do something. So we didn't know what was going on. We weren't very sure of what the substance was or what direction it was going to take, but we knew the city was being heavily impacted. So we put out an alert at that lunchtime and communicated with all the services to say something is happening. It's among the heroin using community. We are very concerned. There's a significant risk of overdose at this time, and we need to start putting those wraparound supports in place to protect people. So throughout the Thursday and Friday, we obtained a number of samples. They were urine, blood, samples from syringes and the drugs themselves, and we weren't able to actually detect anything of concern. So there was significant work through those 2 days, and important to highlight that we didn't have time, I suppose, to change policy. We had to adapt with what we had. So it was really based on the agencies coming together and agreeing that this was a very concerning time. So we worked with the law enforcement, our Gardaí, their lab, Forensic Science Ireland, who conduct the law enforcement analysis, the state lab, our lab in the HSE, who conduct our festival back of house testing, and academics in Trinity College, who had access to different machinery. So we came together as a very urgent group to monitor and to use ambulance call-outs as our surveillance tool. So we were able to access updates twice a day from the ambulance emergency services data, which would indicate the situation in the city. So we were able to identify that throughout the Thursday there was 34 overdoses within the city, in a small area, which was quite concerning. Generally, and on average in Dublin, we'd get 3 to 4 opiate overdose call-outs a day, so it was a significant increase. Our labs worked together, and our law enforcement officers played a really important role in actually obtaining the samples and moving it to us. So on the Friday evening, Forensic Science Ireland identified that there is a nitazene, so we changed our response. We were extremely concerned, and we upped our status to a red alert for the city. This happened very late on the Friday evening, which is a lesson to services, I think, in terms of how you reach people at after 6 o'clock when services are closed on a Friday. And we had to think of how would people on the street, not in services, see messages. So we very quickly got overdose messages on the road, updated what services were open at that time. I have to credit the services for that weekend. They opened and mobilised their staff. We partnered with the Anna Liffey, and we got information printed. We went around to the main using places and stuck posters on walls. And we put posters in businesses and very public locations. So we had to change how we thought in terms of our communications. We did have a very large media presence, but it was really important for us to be out and about throughout that weekend, actually getting the information into people's hands, as well as naloxone. So while we were out chatting to people and the services where we were also getting anecdotal feedback, which really helped us understand what was going on in terms of the substance and what they were being offered. So this particular overdose cluster was linked with a specific powder which was lighter compared to heroin. It was being sold as a new heroin, a stronger heroin, and people were being told to smoke it because it is quite potent. So it was confirmed as being N-pyrrolidino protonidazine, which was a first identification for Ireland, and is now under intensive monitoring since December by the European Monitoring Centre for Drugs and Drug Addiction. I suppose in terms of risk communications, by the Sunday we did see a decline in overdoses and people were declining the substance. They didn't want to buy it due to the risk. With the risk communication, there's always a risk of that product being moved to a different market, and this is what we did see. So usually they may move to another city and generally move on in terms of the sizes of the city. So we did see this substance, and it's been confirmed as the same batch moved to Cork. That was early December, and by the time this substance had reached Cork, our guidance had reached the area and they'd already established a local early warning group. So they were able to detect this substance very, very fast and respond very fast. So again, we mirrored the response in Dublin. We got the information out. They had services on the streets and they were putting posters in public locations that people were using in. In terms of just some top tier lessons from managing the two outbreaks, what we're looking at and reviewing, and we definitely know, our frontline service providers and peers are essential in detecting the change. So we're trying to collate as much anecdotal feedback as possible at the moment and review as many cases as we can. Not everything we've reviewed has been nitazenes, but it's really important that two-way communication continues, and that there is a transparency between us. The rapid escalation has been really, really, really crucial to us to detect those signals. The anecdotal feedback, if sent into us, we will manage it, and we did learn a significant amount from the feedback from people on the streets throughout those two outbreaks. Undoubtedly, naloxone has saved lives, and I see there's a question in if naloxone works. It does. We don't have data; it's very hard to measure, but we know, given the scale of the size of the impact that impacted Dublin, that we definitely did save lives. Just to say, there was 57 overdoses through those days of the Dublin overdose. They were non-fatal. We're working with the coroners to review possible deaths for this time. The data just is not available to us at the moment. We do know, as I said, that the risk communications can have an impact, and we do know that people will be seeking nitazenes moving forward. So we now need to prepare our services on how we're going to work with those people. So in terms of adapting our harm reduction, I think it's really important that both injecting and smoking carry risk. So we know that people were being told to smoke. We also were seeing overdoses as a result of smoking. We know that of the cases of hospital presentations, we've reviewed biological data there, and the nitazenes have been used as part of a polysubstance pattern. So working with people, if they are using nitazenes, to look at minimising how much is used and harm reduction there. For us, I know this is slightly different to the UK, where traditional drugs such as heroin are adulterated. We are aware that this is at the moment in a light brown powder, so we can communicate that, we can provide images on that. We know that people are being sold this with different terms, but we are unsure of what direction this market can take. We can't say use alternatives. We can't guarantee the safety of other substances, particularly in terms of what we're seeing in Europe in terms of falsified medication. So this this is something we have to continue to monitor. In terms of our harm reduction, as Steve said, we can't wait. We need to act now. So people have to have their safety plans in place, their buddy systems, adapting what harm reduction will work for them in terms of what we can do right now, because we cannot wait. So preparing families, preparing communities, this all has to start happening now, which is a message that we're communicating nationally. We are communicating and we're trying to be very transparent in terms of updating our information online and terms of what we're aware of, and we'll continue to update our communications and social media for drugs.ie when we receive information that's valuable. We did issue another alert at the start of February where we were aware of a second batch, which was Nitazenes, also a first identification for Ireland, and we put that out again very late on a Friday. These things seem to end up on our desk, and communicated and tried to be as transparent as possible that we know that they can now come in many different powders, but there's still many unknowns. So we're just asking everyone to be careful and to try and apply as much harm reduction in what they can for now. So in terms of our ongoing response, it's really important to maintain awareness with both service users and service providers. We've established a national red alert group with a number of different stakeholders, including law enforcement, our labs, our ambulance and paramedics. And we meet regularly and we're in contact regularly to review the situation and are working on a number of resources. So we've interim guidelines for areas, which I'll briefly touch on, monitoring and reporting guidelines, and fact sheets for medical care providers to be prepared. In terms of our national preparation guidelines, we issued these in December and we're updating them. I won't go into these in too much detail because I think I've gone over time slightly, but just to highlight, these are the key areas we want areas to think of. We need frequent reporting, even anecdotal information. We need harm reduction preparation. Naloxone preparation is essential to start the planning process now, to start thinking about what happens if emergencies present in your service, and really importantly, preparing with people who use drugs. So our interim guidelines are looking at how to monitor and what type of information we want. It is difficult. I appreciate that people are firefighting on the front line, but any signals of change are really important to report so we can and investigate. And as I said, not everything is Nitazenes, but that transparency is key. Sample collection has been really, really valuable, and it was really important for us to name what was going on and to know that it was a Nitazene in terms of our communication and in terms of our alert status. So we're looking at used paraphernalia, that's syringes, cookers or spoons, and we're very fortunate that we had started some syringe analysis in the preparation for this. Biological samples again are useful but can take time. So what we're asking our services to do is to keep syringes from overdoses or paraphernalia, or if there's drugs, if they could keep them and move them with law enforcement. Really important, and I kind of suppose a key message, while we have time to prepare, while we do know there's still heroin in circulation, we need to prepare, as Steve said, we need to prepare with people who use drugs in terms of what they're seeing locally, how they want to receive information, what type of information, how do you reach them if services are closed. We need to look at if they are seeking Nitazenes, if they do want them. It's really important for us not to create stigma. If people do choose to use Nitazenes, we want to keep them engaged in our services and help them reduce harms without creating a perception that we are judging their use in any way. It's important to keep that transparent piece open so they report changes to us and that can be investigated, and to, I suppose, starting encouraging them to promote naloxone and open discussions on trends in their communities. In terms of risk communications, just to highlight, we did have some concerns in the lead up to the outbreak in terms of a fentanyl narrative in the media, and what we found with this was that it was quite unhelpful, because when the Nitazenes did present, people had believed they were using fentanyl, or people had believed that fentanyl was the more dangerous substance. And we do know from early studies that the type of Nitazene that we saw, prolodinoprodionidazine, could be 25 times more potent than fentanyl. So we need to ensure that we get our risk communications right, that people take it seriously, and that they do make those changes when they need to. So we need to let them know who is at risk, where it is, the date, and what's occurring. But importantly, we need really clear harm reduction recommendations to support those people, because it does cause a lot of concern, and we did see a lot of people very concerned through the outbreaks. In terms of our preparation, just finishing off, we didn't have time for very large changes, and we had to adapt within our existing networks, and I suppose we had to adapt for a health focus, and we did see that across law enforcement and all of the agencies. We need to involve people who use drugs. We do need investment, looking at the situation where heroin may disappear from the market at some point. We need to look at what we need to prepare for now, and we do need increased drug analysis. Just to also highlight before I finish that we are concerned about other substances at this moment in time, particularly new psychoactive substances in tablets, such as bromazolam, and the changing benzodiazepine market has been significant with a move away from legitimate products. We will be updating communication on this for our services next week. It is another area of concern. Another area of concern is the cannabis market, and there's a significant user group at risk here. Synthetic cannabinoids can now appear across herbal vape and edibles. We are seeing more potent substances and various new psychoactive substances appearing. So this does show the need for a formal early warning system and increased drug checking. So we do have a number of issues and user groups at risk, as well as the Nitazenes. So that is it from me. I'm sorry if I've gone over time, but please feel free to put any questions into the box. I tried to get a lot into that there.
Thanks, Nikki. No, you weren't over time, just on the button. Very interesting. I'm sure the viewers will find it very useful in terms of that real life kind of experience of being able to plan that response to that incident. And I think highlights the importance of the role between a collaborative approach to these responses between the statutory and the voluntary community sector providers on the ground, and a very strong communication that needs to take place. So I think there's a lot of learning there for us. We'll move on to our next speaker, Kevin Bailey, who's the regional lead for drugs and alcohol in Northern Ireland. And just before Kevin, you come on, just to remind people that you can put questions in the Q&A, and if you see that there are a number of tabs in the Q&A, if you go to the answered tab, you can see where the responses have been given to previous questions. So keep the conversation going. Kevin, I'll hand over to you.
Thanks, Gary, and thanks, Nikki and Steve, for your excellent presentations. Lots of food for thought there. I'm just going to share mine now, and hopefully that will show in a second or two. Can you see that okay, Gary?
Yes, that's great.
Okay, thank you. So just in terms of the presentation this morning, folks, some policy context for us here in Northern Ireland. Conscious that there will be local individuals and also folks wider afield across these islands. So our local strategy, the substance use strategy, was launched by Minister in 2021, and since then, Public Health Agency, along with partners in the Strategic Planning Performance Group and a whole range of community, voluntary and statutory organisations, including people with lived and living experience, have been really working to develop a commissioning framework and implementation plan, and that's nearing its fruition, and will, all going well, have final sign-off by April of this year. And the reason I'm flagging that is because of our strategic context, because we're thinking about how we deliver services locally in Northern Ireland across key aspects. So our first key strategic block, almost, if you like, is that prevention and early intervention, and both Nikki and Steve have talked about that in the context of Nitazene. Secondly, the important block in there as well is around harm reduction, harm minimization. How do we reduce that harm as much as possible? Our third aspect of that, looking really at the whole idea of access to high quality treatment and support services across the range of our sector organisations. And then finally into that space around recovery orientated services and integration into communities as well. In terms of the plan itself, we're looking across those areas in many ways, but there's a few things I'd like to pull out here today which really impacts on the whole aspect of Nitazene. One of those things is the prevention piece, which is also a health aspect, but also it's also a legislative perspective and an enforcement perspective. We are working very closely on the ground at the minute with our local partners, the Police Service in Northern Ireland and also Border Force and others, to try and identify and detect and ensure that the supply isn't coming into the market, including conversations with Royal Mail, because quite a lot of our Nitazenes that we are seeing, as well as other substances are able to be bought online, both on the dark web and normal web, and they're being shipped across from various countries like the Netherlands, like China, and also from some bogus sites in the UK as well, coming into Northern Ireland. So it's crucial that we work in partnership in that process. But one of the things that I think is really important in that space is recognizing where we're starting from. And the item 3 there on your screen is a trauma-informed system. If we don't recognize as a Northern Ireland PLC and don't put in place a trauma-informed system across our health and social care, our education, our policing, and our civil society, we will continue to see the same impact of nitazene and other synthetic opioids coming to the fore, because ultimately people are engaging in those substances for a range of different reasons, but quite predominantly having previous trauma of some description, be that developmental trauma, childhood trauma, trauma from the Troubles, or something else in terms of psychological trauma. And we need to recognise that nobody in Northern Ireland or further afield wakes up of a morning and wants to say, I'm going to be addicted to a particular substance today. We don't do that. People use it for various different reasons, and I think the family support aspect that we're trying to link in with this whole work is crucially important, because it's not just the individual who's using the substance or the index patient who needs help and support. It's that wraparound support that's crucial, and we know that we have on there as well stigma. Stigma kills. It prevents people from engaging in services. It prevents people from reaching out, and we need to tackle stigma, and we need to increase help-seeking behaviour. So that's a lot of the work that we're looking at doing across the next couple of years here in Northern Ireland in relation to our strategies. In terms of the nitazene specific aspect of that, Nicky's already highlighted the remand made in the 50s, never approved because of the issues around potency. But they do tackle and target the same receptors as morphine and heroin. So the mu, the delta, and the kappa regions and receptors of our brain are impacted by nitazenes and much more potently than morphine and heroin would ever do. We've already heard there from Steve some of the facts that nitazenes have been targeted across the UK. We're seeing that in a whole range of substances. In terms of the opioid market, heroin, oxycodone, it's absolutely there. Benzodiazepine, which is a real concern for us, in particular here in Northern Ireland, because that's a bigger usage of concern right across our local communities. We're seeing synthetic opioids in the likes of diazepam and also in cannabis products. And part of the challenge there as well, particularly around, say, for example, the last piece around cannabis products and synthetic cannabinoids, there's an increasing concern at the minute around young people in particular, children and young people from primary school age, so under 10 years, 11 years of age, who are vaping, but also some of those individuals who are vaping and potentially vaping illicit substances as well, which is a real concern. So in that space, there's an issue around whether or not people are knowledgeable and aware that nitazenes are contained within the substance they're using, and also that inadvertently is going to cause some risks for what they face, and particularly for children and young people who are maybe testing out at a point in time and haven't got a real sense of what that drug is and how it's going to impact them. That's a real concern for us, right through to the individual user who's been using for a long period of time. We recognise and see the impact it's having there. Some of those impacts that many of the members on the screen might know about already is that they're similar to similar to other opioids, but have greater potency. So some of those things that you see there on the screen around relaxation, some of the reasons why people might want to do that, or euphoria given some of their troubles and trauma that people have experiencing. But you can see that there's other things around the falling asleep, nodding off, and that causes a real issue around respiratory issues when people go into that sleep, particularly with the impact of nitazene. And so that causes a potential higher risk of overdose. The issue we're seeing with those synthetic opioids is the potency. So there's no telling in advance how they're going to affect the individual, and the makeup of the individual has a direct consequence to the type of drug that they're using and also the impact it has on them. So it's really easy to take too much, which will ultimately lead to an overdose. But as we've already heard this morning, even a small amount of nitazene can lead somebody to an overdose. Some of those things that we're seeing in terms of the other factors, the personal factors themselves, so how the person's using it. And we know through some of our engagement with individuals locally, some people will use without much much care or concern, and others will be much more conservative in their usage. And we've seen through some peer-to-peer conversations support where individuals have noted that the nitazene that they've tried is different to what they normally use, and are using that information to share with other peers, which is, in my view and view of colleagues, has potentially saved lives over the past couple of months since we've been dealing with this issue. The individual themselves, if they're using other substances, such as heroin, prescriptions, opioids, or certainly benzos, or indeed alcohol, that whole idea of polysubstance use, that's going to create a real concern. And certainly for us in Northern Ireland, when we look at drug-related death figures and we look at overdoses, and when we engage with services on the ground, polysubstance use is probably our single biggest issue that we're experiencing across all of our services, right across the sector. And certainly when you look at some of the death data, the vast majority of people who have died have had multiple substances in their system at the time of death, and each one of those deaths is an absolute tragedy in its own right. The one about individuals previously stopping and then maybe starting again, it's particularly relevant to our process around the pathways into and out of criminal justice. We see that very readily, where in the first 7 days of release through the criminal justice system, people have a lower tolerance and will go out and get access to a range of substances, and potentially take the same range that they took prior to incarceration. And that's a big challenge for us, a big issue for us, because in Northern Ireland context, we have a really high remand population compared to other jurisdictions across the UK and Ireland as well. In terms of the potency element, and I mean, Steve highlighted his seed earlier on about the 16% heroin purity. We have no way of telling in advance around the potency of the synthetic opioid, but it's often more than what is expected to be from normal opioids. And the individual sometimes is consuming those without knowing. So I know that there was in the south, and like you raised it there was that sense around of market testing with nitazene. We haven't seen that same thing here in Northern Ireland. We've seen that adulteration with other benzos and with other opioids. So there's a potential to consider how that might impact individuals, depending on where they're buying their substances from, and whether or not they're doing that on a cross-border basis. And we know people do that on a cross-border basis, going between Belfast and Dublin, or Derry and Dublin as an example. And also the aspect of how the person is ingesting or taking will increase the risk. We could have said previously around heroin, for example, to smoke that because it's a harm reduction technique. And actually at the minute, that's not the same case when it comes to synthetic opioids. And more importantly then as well, we're encouraging the fact that individuals don't use alone, which is a key harm reduction message for all of our services and the work that we're doing on the ground. Some of the aspects of potency have been touched upon already, but I wanted to flag this to the colleagues on the screen in terms of the synthetic opioids. There's lots of different figures out there about relative potency to heroin, and we've heard some on the call this morning, but just even to look at that screen there, when you see the fentanyl 50 times more, metanidazine 50 times more, protonidazine up to 100 times more, and there's more again, as Steve had highlighted. And I think the thing that this really says to me is that no matter which form or formulation of nitazene that we see locally, it's going to substantially increase the risk for our drug using population, and we need to educate them as best as possible, and we need to do that in a peer-to-peer way so that we can get the clear, concise harm reduction messages across to that particular cohort. So in terms of our local context and our experience, many colleagues on the stream will be aware we have a drug and alcohol monitoring and information system known as DAMIS, and that links into all of our community volunteer and statutory organisations to use information as an early alert system that is being found out in local communities, bringing that in centrally through to the PHA, and then sharing that on to a range of partners as appropriate with harm reduction advice and guidance, which is then permeated down to individual users who are engaged in a range of our services. Our first alert around metanidazine came in June 2023. At that time, we were seeing something different to what the UK was seeing. So, in parts of the UK, they were seeing powder and heroin form of nitazene. We were seeing it in tablet form here at that point in time, and we were linking with colleagues in OHID around that issue. And there were absolutely growing concerns of overdoses linked between June, July, and August period in Northern Ireland. And in a short period in July time, we did have quite a number of overdoses across a couple of days from Belfast, Lisburn, and Ballymena area. That resulted in, again, conversation with colleagues on the ground, services providing both drug and alcohol services, but also housing and homeless services. And we agreed then that we would put out a patient safety alert. So OHID had issued a patient safety alert at the end of July 2023. We engaged then with colleagues in the Department of Health to issue a similar alert locally, and that went out to all the organisations that needed to receive that right across the health and social care system. And then also we were conscious of linking back in our colleagues in the south then and at the Dublin period of November, where, as Nikki had said, there was that 57 overdoses in quite a short period of time. I think that the worry and the concern at that point was, are we going to see something similar in Northern Ireland context? Now, thankfully, we didn't see the same level of overdoses being presented in Northern Ireland at that time, but there were a number of overdoses and some fatal overdoses at that time. But in those cases that we are aware of, again, polysubstance use was a key contributor. It wasn't just a single drug such as nitazene at that time. In terms of our ongoing work, we have a good working relationship between the police service, forensic science, and PSNI, and we're working with our colleagues in the community voluntary sector and statutory sector to ensure that we can get a hold of substances as they become available to get that tested and provide additional updates around harm reduction advice and guidance. One of the challenges there is sometimes we experience the individual has used all of the substance, or potentially at times has flushed the substance or thrown it away. So it does prove somewhat challenging to get a hold of some of those substances to get tested. And again, we're creating those links between forensic science in Northern Ireland and also forensic science in Ireland as well. We need to continue the ongoing encouragement of peer-to-peer harm reduction messages. That is one of the most important ways we're going to get that information out to individuals. And then we need to keep that connection going across the UK and Ireland. We did in December of 2023 have a number of wraps of what was sold as supposed heroin tested from different parts of the country, and in those two examples that were tested, there was actually no heroin trace found. It was paracetamol, caffeine, and nitazene, which was a worrying development there. But we haven't had any further confirmations of that being sold locally, or haven't been able to get any to test in the local market. In terms of the ongoing work, then part of that, and it's been raised by other contributors today, our take-home naloxone program is a big part of our work to prevent overdoses and reverse those overdoses. So in 2022-23, we did over 1,800 packs dispensed. That was just over a 25% increase from the previous year. And you can see from the screen there that we also have reports back that was used 199 times in that same time period. I suspect that there was more usage of take-home naloxone. We just haven't had that recorded because we're going through a process around how we introduce a harm reduction system to have that more accurate data, which is crucial. We are very shortly in Northern Ireland going to add additional formulations to the market. Nixoid, which is the nasal spray, and also the Pebble. The Nixoid is a 1.8 milligram dosage, and the Pebble is a 1.26 gram dosage for naloxone, which will be available to local organisations. And we're actively engaging in the current government proposal to expand the take-home naloxone. If anybody on the screen hasn't responded to that, it closes on the 6th of March, so please do respond. And with that as well, thinking about wider issues, not just of overdose with nitazene, but also thinking about BBV and also other contamination, we've opened additional needle exchange and syringe services in our Banbridge and Portadown areas. And then we have active ongoing engagement with individuals with lived experience. So I'm conscious of time, and just this is my last slide, just to talk about some of the future considerations we might need to think about. We need to be able to implement the legislation on the proposal to expand take-home naloxone, and there's going to be two routes around how we do that, and we haven't got time to go into that now, but PHA will oversee that process in Northern Ireland once the legislation has been approved by the UK government, and that will include also the implementation of the harm reduction system. Many of our colleagues on the screen will be familiar with the NEO 360 system, and that's crucial to have a data-driven approach so that we can understand the type of information we need around the hotspots and administration of naloxone and how lives are being saved day and daily on the ground. And we will continue to monitor the need for the expansion of needle exchange services across the region. And just this week, we're in the process of introducing individual testing strips with Nitazenes as part of our needle exchange. I want to flag, though, just a comment on that there are lots of different individual testing strips available across different suppliers, and they will work. There is some challenges around, though, false positives as well, so we need to work and bear in mind that those testing strips may not always be 100% accurate, and so harm reduction advice and guidance is still required in that space. And we want to be able to learn from some of the work that's happening in Bristol at the minute around how the bigger testing process is going to take place there. And then we have active engagement with our individual lived experience that must be at the centre of all that we're doing. We have to challenge that stigma. We have to increase the help-seeking behaviour, and peers with lived and lived experience are crucial to that. We can't do it without them. The DAMA system that I mentioned earlier then as well, as part of that process, one of the things we'd like to do, which is an action of the strategy, is to review DAMAS, and we're going to take a tabletop review around testing and link that with DAMAS within the first quarter of 24-25, and that's to ensure we have that connected data capture, analysis and reporting process locally, because there's lots of things that we are aware of on the ground, and we need to make sure that we can streamline that information flow, that it comes into a central source and then can go out to local organisations on the ground and ensure that those who need that information around harm reduction advice and guidance can get that. And I think it would be remiss with me to leave without saying that we want to keep a watch and brief over the consideration around overdose prevention centres and how they're going to develop. We know we've got one developing opening in June in Glasgow, and one opening in Dublin in September, which are currently planned. And I think there is an issue around the model about how that looks if something changes here in Northern Ireland. There's been some local developments in Belfast around support for this, but the legislative requirements are still enshrined in the 1971 Act. It is not a devolved matter currently, and it is a reserved matter with the UK government. So we are certainly watching with anticipation about how they roll out. Should something like that roll out in Northern Ireland, for my view would be that it needs to be a full consumption room, not a safer injection site, given our issues around benzodiazepine and other polysubstance use. So we'll need to keep that under consideration and work with policy colleagues and UK government colleagues as those developments start to become a bit clearer across other parts of the UK. So I'm conscious of time, and I've got a message already to say I need to be on time. So that's all I want to say, Gary, this morning, and we'll be happy to take comments at the panel at the end of the session. So thank you.
Thanks, Kevin. Very helpful. Give a context the local policy approach and where the Public Health Agency and the strategy is going with this. Our next contributors are from local frontline services. In terms of the people that we see around, we'll see the emerging trends around emerging drugs. It tends to be more visible, first of all, within those most vulnerable groups. So we've asked for low threshold and hospital services providers to contribute their perspective about what they're seeing on the ground and what they see as the relevant current issues moving forward. So I'm very pleased to have Derek McParland from Same Community, Ian Buff Cameron from Extern, and Tim McQuaid from DePaul, Ireland, to provide that local perspective. I think Derek, you're gonna lead on this.
Yeah, thanks very much, Gary. First, thanks very much to all the contributors today. It's been fascinating listening. I think the thing that myself, Tim, and Buff had a conversation around this, and we're all in agreement of what needs to be done, what we'd like to see done. The first one that we would like to talk about is the expansion of the naloxone provision. This is a necessity. So if there is, and there more than likely will be, an increase of nitazenes coming to Northern Ireland, we need to have naloxone increased. Evidence has shown, so I can recall one that was found in the BT47 area of Derry, where there was a blue tablet that tested for methanidazine and bromazolam in the one tablet. So taking that into consideration, and as Kevin had mentioned previously about how we would use an awful lot of pharmaceutical medication, well, illicit black market pharmaceutical medication, we need to be looking at naloxone provision for not just your atypical opioid user, but it needs to be for everybody in Northern Ireland. So evidence has shown that nitazenes are in fake pharmaceutical medication, and therefore will affect a large number of people who are unaware that they're taking this potentially fatal drug. Taken into consideration with that, we would also like to see the expansion or the introduction of not just naloxone, but flumazenol as well, because Northern Ireland needs the introduction of flumazenol. The data is suggesting that flumazenol can cause seizures much easier to deal with than death. So we need to be looking at both naloxone expansion, naloxone provision, and flumazenol. That is the number one priority within Northern Ireland. I'm glad the naloxone provision is, we're looking at the legislation so we can expand it. And I would echo what Kevin has said, that anybody that hasn't basically been on this here and contributed to this, they need to be, because this is a vitally important part. The next one is a massive bugbear of mine, and I think just seeing, for example, what has happened in the other nations and the Republic of Ireland proves why we need this. So the availability of rapid testing, Northern Ireland doesn't have any, and it's quite frankly a disgrace that we don't have any. The Republic of Ireland saved lives because of rapid testing and rapid information given out to people there and then. So hats off to what was done in Dublin. It literally saved lives. We are working in the dark ages when it comes to this. At present, we have no rapid testing. In the UK, there are several areas that have rapid testing, and work with organisations and local police to ensure that this works. In the Republic of Ireland, we've seen rapid testing helping to get a strong harm reduction message out, which saved lives. We don't have this at the minute. A lot of these organisations, for example, Simon Community, Exeter and DePaul, we rely on the likes of Wednos. And Wednos is an amazing organisation, but we need rapid testing there and then. We need the information given out to people there and then. I remember a couple of years ago, there was a black and green Xanax in Belfast, killed 6 people. And it was weeks before we got the information out that it was a Nitazenes, which is an extremely strong research benzo that kills so many people on a yearly basis. The next thing we would be calling for is improved communication via databases from all 4 nations and the Republic of Ireland. We're all intrinsically linked. It is imperative that all 4 nations are communicating with each other, and this includes law, statutory, voluntary sectors, as well as governmental officials. The governments do need to be on board with us. Then this isn't an ideology thing. This is people's lives that are at risk. We all need to be talking around the table on this. The next one, and I'm glad Kevin brought it up with regards to DAMAS, we do need a more up-to-date version. DAMAS served its purpose at some point, but we need something more up-to-date. I've been thinking quite a lot about with regards to what we can, and for example, in COVID, we had like the test and trace app, which was really, really good because it gives the geolocation where somebody came into contact with the virus. So there's no reason why we can't have, for example, the Lisburn area. There has been contaminated supply found in the Lisburn area. People who have this app can be alerted to this here in this area. Things like this will save people. So a trace and trace app was very easily built. There's no reason why we can't have some app that not just professionals use, that service users can use, that every member of the public can use. The next one, which needs to be done, and the likes of Buff will be able to talk much better than I can on this, but overdose prevention centres clearly show, all the data shows that they save lives. We need to be proactive rather than reactive. If nitazenes, and if and when, more likely when nitazenes come into Northern Ireland, there will be deaths. And the only way to stop this is through overdose prevention centres, and to give these people the support that they need. This isn't a criminal issue. This is a health and social issue, and we need to be looking at that way. I would also, and I spoke to, again, all my colleagues in this, and Gary as well, like, our training in Northern Ireland is very, very strong in regards to harm reduction. What we need to do is resist the urges from different people to have the sort of the message in the training we get across to be like the US model of the fentanyl fear crisis, a bit like the cannabis fiend in the 50s and 60s. That killed people. That didn't save lives. We have excellent training in Northern Ireland. ASCERT deliver absolutely brilliant training, same with Exterm. But we need to be rolling this out, not just to this sector. We need to be rolling this out to everybody. We need to go to youth centres. We need to go to schools. We need to go to places of work. Everybody needs to know about this, because Nitazenes aren't going to affect your atypical drug user. They're going to affect everybody. Okay, so we need to have strong harm reduction message, not that fear narrative that doesn't work for anybody. So the other thing, again, Kevin was glad Kevin said is the introduction of the Nitazene test strips. And again, we need to advertise that they're available. We need to make more people aware of it. This is a really, really strong thing. And the expansion of the needle exchanges, I agree with what Kevin was saying with regards to bloodborne viruses as well. Everything, all this is intrinsically linked, and goes back to my viewpoint that this isn't a criminal issue. This is a health issue. This is a social issue, and this is something that impacts us all. And the last one, as mentioned previously, all evidence suggests that the Nitazene issue will not just affect your atypical drug user. So strong education must be given out province-wide. It can't just be to, sort of the vulnerable that we see as a vulnerable, the homeless population or the drug using population. We need to be getting this message out to everybody. We need to not hide away from the fact that people take drugs. Everybody in society knows people that take drugs. If it's from your families, from your friends, from acquaintances, everybody's taking drugs. So we need to stop hiding it and going, oh, this is just an issue with homeless people. It's not. It's an issue that happens everywhere. I guarantee you, somebody goes out to a restaurant tonight, you could walk into a bathroom and somebody's taking cocaine. It's something that's happening all the time. So we need to stop hiding it and talk about it more in society. It's not society's dirty little secret anymore. It's something that's out there. I've went a wee bit ranty on it, but I'm sorry. Unfortunately, I'm sick of seeing people die. I'm sick of seeing the same things happen over and over again. We need to change what we're doing in Northern Ireland. I genuinely believe Northern Ireland is a very, very strong harm reduction country. We've a lot of really good people here, but we need to be the leaders in this. We just can't wait and react to see what everybody else is doing. Tim, Buff, if you've got anything to say.
Certainly, I would echo absolutely everything that Derek has just said. As frontline organisations, we see day and daily the impact of an ever more complex substance market in Northern Ireland. Last year, DePaul saw a 60% increase in the number of overdoses in our services. 60%. 57 individuals requiring naloxone intervention. It was interesting that Kevin had touched on the numbers around naloxone administration being difficult to accurately calculate, and I'll demonstrate just how right he is in that, because we administered it 140 times just in DePaul last year. So that's 140 administrations of naloxone among frontline staff. That has saved lives. We can't stress enough that we must have an objective to make a vast improvement in health-related interventions across homeless services to prevent overdose and death. Again, Kevin is right when he speaks to the fact that trauma is very much at the heart of what many people are the causes of substance use for many people that we work with. And at this moment in time, 1 in 4 presenting to our services have taken substances in the past year in substantial amounts, enough to cause them concern and to cause us to seek the support them to reduce the harm they're experiencing. It's very sobering. And look, just also to say that as Derek touched upon, without testing, we're in the dark, but we know what we know, and we're seeing people at much higher risk than at any time in the last 20, 30 years when it comes to substance use and risk of death. It's just unparalleled. We've not seen anything like this. And as Steve touched upon, this may just be the start of it. So very sobering words, but words that must be said. Buff, is there anything maybe you'd want to say as well?
Yeah, just I agree with everything you've said, Tim, and everything that Derek has also said. Don't want to labour the points. The points have been well made. I would just add that I believe that we are in a unique position here in Northern Ireland. We always kind of have been, and I've been saying this for many years. We're at the end of the drug market, and things usually hit other countries before they hit here, which gives us preparation time, gives us knowledge, and it gives us the ability with a bit of hindsight to know how to respond to these issues. We are still talking about overdose prevention facilities or drug consumption rooms as being new initiatives that need to be tested and proven. They are tested, they are proven, they've been operating for the last 20 years in countries around the world. We don't need any more research. We don't need to wait and see what happens in Scotland or Dublin. The research is there. Let's follow it and let's do it soon because it will stop deaths. It won't stop all deaths, as Derek has outlined. We know that nitazenes have been cut into our benzo supply, potentially into the cocaine supply in other jurisdictions, and those people will not likely use overdose prevention facilities. Although I was very interested to hear Kevin talk about drug consumption rooms or looking at wider than just safer injecting rooms. I think that's something we should definitely explore. And secondly, then, and just lastly, drug testing. We have access to the equipment that we need on the ground here in Northern Ireland. We can do that in cooperation with the PSNI, with our colleagues in Queen's and other organisations. There's been a lot of discussion in the background through the Drug Deaths Task Forum that was set up following the deaths of the nitazenes, and we just need to push that forward quickly because that will save lives. One thing that worries me greatly, we all know that Scotland has the highest drug-related deaths in Europe, except in one area, and that area is between the age groups of 25 to 35, where we hold the highest drug-related deaths figures, and that is absolutely frightening to me. We have a younger cohort of people using substances in a very, very dangerous way, and we know that drug use does not happen in isolation. As Kevin highlighted, nobody wakes up in the morning and says, today I want to become a dependent heroin user. It happens in and around peers, it happens through social groups, and people make decisions and use substances. And the more that is happening among our young people with wrong information, no access to accurate information or safe places, our overdose deaths are going to continue to rise. So let's do what the research has been telling us to do for many, many years and move this forward. I think we have more support now for harm reduction initiatives than we've ever had in Northern Ireland. We had Belfast City Council coming out with a vote supporting the establishment of overdose prevention facilities. We have our Belfast City Chamber and business communities actively supporting needle exchange. And I know, working with colleagues throughout the rest of UK and Ireland, that people are envious of some of the things that we have here because of that. So let's build on that. We do a lot of things well. I'm extremely proud of our needle exchange responses. We give out a lot of harm reduction equipment through that. I'm extremely proud of our naloxone response. We were early in provision of naloxone. We have the PSNI carrying naloxone. There's a lot of things we do well. There's a lot more that we could be doing. Thank you.
Thanks everybody. Before I hand over to Anne to do the Q&A kind of discussion, I think that what we're hearing are a lot of very pertinent, kind of, very specific, kind of points around what the issues are on the ground and what our approach needs to consider here. And I want to pick up just on the point that it is, we do need, I think, to have that balance between being able to be prepared now and to be engaging in order to have that preparedness, particularly among those in their most vulnerable groups who are more likely to be the first adopters around some of these substances, but that there also needs to be a preventative approach as well, because this is going to be a long game. It's not going to be a short game. And, I think that, acknowledging that we have, services like our connection services in the community. We've got targeted prevention services working with young people, and that they are, they are methods of engaging with young people as well as professionals around raising accurate awareness around what is actually going on and what the actual issues are on introducing these drugs. And I know that is starting to happen, and that synthetics are areas that are being included within education programs now. And I think we need to be real about what the actual environment is. And within our own youth treatment services, we have seen a 20% increase in the last year of referrals, which indicates that what we know is that the instances of problems being experienced through substance use is starting to manifest as problematic issues at a lower age range, which obviously has to be a matter of concern. Okay, Anne, I'm going to hand over to you to chair the discussion with all of us. There's a lot to talk about, I think.
I think, there's been many very good, strong points raised by all of our presenters, and I just want to reiterate our thanks from ASCERT and from ourselves here today. And we have we've at one stage up to 287 people who have tuned in to listen to the very important points made. It was great to hear from our local representatives, Tim and Derek and Ian, and of course Kevin, who's leading on our strategy and is really pushing things forward in a pragmatic fashion. Always fantastic to hear Steve Rolls, because he really condenses for me the context of the issues and things that happen far away in different countries that we don't think about, and how it trickles down to us and to our people who are working on the front line and to our people who use services. And one of the things that really stood out for me when he said, from an economic perspective, if you're coming in and you want to bring in a 50 key of heroin or a matchbox full of Nitazene, which one would be more sort of economically beneficial? And to me, that really stood out. I think that the presentation from Nikki is the one it's about the preparedness. It's about having everything in place. We are not in the game of scaremongering or some prophecy of doom. We need to be prepared, because when it hits, and it did hit Dublin, it hits very quickly. And as Nikki pointed out, then that the economics kicked in again, and the vendors then moved to a different place. So hearing all those different ways of coping with the issue in a collaborative, collective, and fast, rapid response, which is it's the, I suppose, the essence of what we're trying to get across here today. But also not just about the Nitazenes we do, as Kevin mentioned and other people have mentioned, we still have huge issues with the designers, with the bromazepam and the fluoprazolams and the many designer benzos, and it's to the forefront of our desks. And again, and I have been banging on about this, Ian Buff has mentioned there, it's about our young people. We do have the second highest rate of drug deaths in the UK, and that's within our 18 to 35 age group. And that is something that's just, for me, that's the standout issue, alongside the advent of Nitazenes and other synthetic opioids. Now, we've had a raft of questions, and I think the prize goes to Steve for answering those questions the most and very quickly. So thank you, Steve, for that. There's still a few, if I may bring a sum up. So question from anonymous attendee. if I can read it out, are there any plans for you to address the Health Committee in Northern Ireland? Because this was discussed yesterday. It was mostly COVID laws with Nitazenes thrown in at the end. Lots of blank faces and unanswered questions. I would say that the MLAs could definitely benefit from your experience. Does anybody want to answer that question?
Maybe if I say something to that effect,
Yeah.
I think the health committee is one particular avenue of individuals that we would want to engage in a range of activity around what's happening across prevention, intervention, and recovery, and certainly from a PHA perspective, we engage readily with our policy colleagues in the department. Many of you will know Gary Maxwell and Michael Harkin, who are familiar to lots of organisations who've been around for a long time. So they really help us steer that connection, and will link with local politicians as well. And certainly there was conversation at the Health Committee around the scheduling of Nitazenes yesterday as well. The UK government are going to schedule 14 of 16 new Nitazenes. So I think as those opportunities emerge, we can certainly engage with the Health Committee, but it's also important to engage with lots of different people at lots of times. So sometimes politicians will want to say something specifically about an issue because it's within their consistency or it affects part of their population. So I think it's useful that they have the right information at the right time. I think it's also useful that they're engaged in a way that doesn't sensationalize information, and I think it's crucial that they're reporting factual and accurate information when that happens, because unfortunately there have been some times where we've seen that not be the case, and I think there's active engagement with our local politicians on an ongoing basis, not just from a statutory perspective, but I know many of our community voluntary members on the screen engage readily with local politicians on a day and daily basis.
Okay, Kevin, thank you for that. So Stephen Ward has a question. Kevin, back to you, Kevin, but I'm going to bring in other people as well, if I may. Kevin made a comment about consumption rooms, alluded that there were two different thoughts about how these should look. Thoughts on that? Kevin first.
It'd be interesting if there only were two different thoughts on how they would look. I think there are lots of positives around consumption rooms. I think some of the narrative around them is that there's evidence base there that they support safety and they reduce overdoses and they save lives. That is undoubtedly true. I think part of the challenge for us here in Northern Ireland is that we have different views around whether or not we can or can't initiate them. We've obviously got the 1971 legislation, which is a reserve matter for the UK government. So the UK government ultimately have to say to us, yes, you can or cannot do this and make a legislative change. We don't have, as Scotland do, a Lord Advocate to say to the police, yes, this is allowed in Northern Ireland. PPS service would have to do that in this case in Northern Ireland. I'm aware that there's some things happening in the background around that, which may or may not come to fruition, but I suppose it's not able to say any much more on that.
Yeah.
What I would say is I do think there will be a place and a space for them. They're not the silver bullet, but they will be part of our landscape going forward. I think the question is not if, it's more about when that happens, from my perspective, and I'm imagining Buff and Co will come in and share some of their views on that.
That's great, Kevin. Thank you for that. Buff, yes? Can't hear you, Buff.
Sorry, muted myself. There are a number of different models, and I think we just need to pick the one that works for us on the ground here. And everybody will be aware that ASCERT are to the forefront trying to push for an overdose prevention facility, drug consumption room, call it what you will. Kevin's absolutely right. The evidence is there to support that it reduces deaths, and agreed that it will reduce deaths in a certain population, but that's the population that is most at risk, particularly most at risk of Nitazenes. And we've heard today that it's that group and that population that will usually encounter problems and issues and new substances that enter into the supply chain. So that's the group that we really need to protect, and we really need to move quickly to do so. I mean, we hear a lot of talk about medically supervised drug consumption rooms, and I would ask people to think about what does medical mean, because I can tell you now that my staff and our staff in extern are effectively trying to manage an overdose prevention facility on the streets of Belfast city centre as we speak, almost on a daily basis. The staff are out administering naloxone, doing basic life support, rescue breaths, and saving lives. We're capable of doing that on the streets and alleyways of the city. I think we're more than capable of doing that in a facilitated room or place, and we just need to do it. That's the bottom line.
Absolutely.
As in relation to whether it's a devolved issue or not around 1971 Act and Westminster, absolutely recognise the problems and issues around that. However, I think we can work with the Public Prosecution Service and the police to get local agreement. I think everybody would agree that it's not in the public interest to prosecute people for trying to provide a harm reduction approach and save lives, and that's what we're talking about.
Good, thank you, and thank you both for the excellent work that you're doing in extern, as well as our other CMV sectors here on the panel and on the call. Steve.
Yeah, just to follow up on the previous comments, there are a range of different ways in which supervised consumption can be provided, and I've visited various super consumption places around the world, from very fancy, expensive, sort of €1 million facilities in Copenhagen, through to effectively just a gazebo and some volunteers in a park in Vancouver that didn't cost anything. Cost is clearly an issue. It's a political issue and obviously a resource issue. I think there's a real concern that that these services are going to be expensive and that they'll draw money away from other services, and I think that needs to be responded to. I think they need new funding, and that needs to happen to make sure that they can move forward. But you can also have very small scale supervised consumption as part of a homeless hostel, adjoining an existing drug service like a needle exchange. I've seen in Copenhagen, I've seen drug consumption services that have drug testing services on site, so you can get your drugs tested there and then with a Brooker FTR, proper drug testing, not just the thing, and then you use them. And I also think it's something I mentioned in my presentation, but maybe I glossed over because I was caning it through so much stuff. This idea of enhanced harm reduction housing. So you have quasi-supervised use in housing for vulnerable populations. So if someone is going to use, they will let a staff member know, and that staff member will then come and check that they're okay. So it's a variation, and it's something that is quite widespread anyway. It happens under the radar, but it's kind of semi-supervised consumption is happening within harm reduction oriented housing already. And I think getting some sort of clear guidance and best practice on that and relevant training could be a really positive and useful way forward as well.
Okay, thank you for that. We still have several questions to get through if we had more time. A question that has been repeated a couple of times is in relation to, and I just lost the question, is in relation to the use of substances in vaping. So I just found the question, Jared. How likely is it that nitazenes are present in some of the current vape oils, such as spice and pine? Does this raise concerns amongst young people in that they could be targeted as a group? And as I speak, Kevin is typing an answer. So all of the typing, Kevin. I know I'm working with the community at the minute in Belfast. It's quite a contained community, and they have a huge problem with their youngsters vaping pine. So I'm sure that's replicated in other areas in Belfast and out with Belfast. Kevin.
Yeah, thanks. I seen that I was responding to it. There's somebody else to say. I think at the minute there's two aspects of vaping. we have a general concern at the minute around the amount of young people vaping, and I would echo Gary's earlier point about the fact that it's younger young people, so they're children in many respects, primary school age, that are vaping, many of whom have never tried tobacco products in their life, but are vaping. And then, so that's one cohort of concern, and then the second cohort of concern are those who potentially are interested in vaping illicit substances such as pine and spice, and we are seeing that more readily. It came up recently at a regional community safety meeting where it's a concern across the different departments, our policing colleagues, education, and we're seeing it on the ground in terms of services as well. We don't, as we currently sit today, have any evidence that there's any nitazene linked product in vaping, but should that be a concern, I think the vaping in general is a concern, and the illicit substances are a concern, and I think we need to do more with that. There is a group working at the minute regionally, led by PHA colleagues from tobacco and drugs and alcohol, working with community involved organisations, trying to understand what's the best messaging that we can put out there in the schools, which is age appropriate, in terms of both a universal approach and also a targeted approach, which we fund through our drug and alcohol services as well. So that process is going to be ready for March here. We're in March now, but the next couple of weeks that'll be ready to be launched regionally, and that will be shared with all the range of organisations and also schools as well. So we can keep people updated on that as it develops.
Thank you for that answer. That's great. Yeah, I don't know who's first, but Derek, I see your face up first, so if you want to jump in.
Yeah, I think that question links back to one thing only: testing. So we don't know, because we don't know what's in the substances. So I'm going to tell you just a quick story. I was working with a client on one of our projects who I knew he was smoking spice in a vape pen. He was under the illusion, no, I know this drug dealer, he wouldn't screw me over, he's 100% all this here. And I was sort of like, right, here's the details of Wednos, send it off, and then if you decide I'm not going to force you to do anything. He sent it off. 3 weeks later, he came back, yeah, I'm not smoking that stuff anymore, because the test results came back that he was smoking spice. He wasn't smoking cannabis oil. That's a perfect harm reduction message. Rapid testing, that guy could see, oh, I'm not smoking cannabis oil, it's actually spice I'm smoking, and it's going to cause me to have seizures and problems with my lungs and stuff like that. So he stopped smoking it. Now, I know they're all not that easy, but that's an example of why we need testing. Simple as that. We didn't know what was in it. He found out.
Absolutely. You're preaching to the converted here in terms of rapid drug testing. So thank you for bringing up that to illustrate the point. Gary.
Yeah, it's just I agree 100% with the need for rapid testing. I think that is at the centre of our capability to be able to understand what's going on at a moment in time and then respond to it. And we need to have that capability. It's not there. But in terms of space and young people, it is the case that, I can say that over the last 6 months, we have seen a dramatic increase in the number of contacts from police, parents, schools, around concerns around young people who are vaping some type of substance or another, and assuming a lot of it is spice or else pain. And it's not in a location, it's everywhere. So I actually specifically put an ask out to get information across our services, and we were getting reports of contact with our connection service, with our target prevention services, and also with DAISY, our youth treatment service, and that was across every part of Northern Ireland. In terms of young people who had been excluded from school as a result of being found vaping, and parents who were concerned, and young people who had become ill, and in some cases had to be taken to the hospital as a result. So I think that is a matter of concern in terms of a trend which definitely seems to be growing, and we're currently trying to seek some funding to put a project together which would target that specifically. But I think that in terms of young people, what we're seeing is that those subsets, vaping is leading to a subset of young people who are then vaping other things and having access to that. And I think the concern is that don't know where that's going to lead. Those barriers are being broken down at an earlier age in order to be able to progress towards other substances. So it has to be a concern.
Okay, thank you for that. Thank you for those comprehensive answers, and I hope that answered the question for the people who brought that up in chat. I'm going to circle back slightly to, I think it's Lois or Lewis, I hope I'm pronouncing that correctly. Dugmore is posing the question, why is it taking so long? Or sorry, is there a reason why screening for nitazenes has been slow to be developed? Well, I'm going to go to Nikki in relation to that, because you're at the forefront of what's happening in terms of the rapid testing and the alert system. So, we've some thoughts on that as well. But Nikki, please.
No worries, and sorry for any confusion. In terms of our analysis at the moment, it's back of house. So we had to adapt really quickly to be in a position to be able to access drugs for health purposes. So generally law enforcement analysis would be the main route in the Republic at present, but that can take time. So we have applied back of house, which means we can access drugs and analyze for health purposes, where we obtain information for harm reduction alerts and monitoring. That has meant that we have, I suppose, skipped policy steps, which can take some time. In terms of the analysis for nitazenes, our experience has been they are difficult to analyze. So in terms of their presence, we use an FTIR, infrared spectrometry, for outreach at the festivals. And generally that won't detect nitazenes because they're in low percentages. So we've had to look at collaborations with labs who have more expensive apparatus. So we've looked at LCMS, GCMS and NMR. So we've had to pool together resources very quickly amongst a collaboration of networks. So what we have found is that the GCMS and NMR have been the best detection apparatus, but they are very expensive to run and to house, and we appreciate that not every laboratory is set up with that material. So I suppose in that sense, from the HSE's perspective, we have to ensure that we are, I suppose, ticking all the T's and crossing the boxes in terms of our analysis before we come out with the results. So that has been why we've had to use that mechanism. I'm aware there's other methods and people may need to adapt, but it's very new and we're still learning. So there's many different types of nitazenes. They in the case of Ireland, and sorry if I missed this as well, they haven't been mixed with other substances. So it has been the nitazene, caffeine, paracetamol, and a small bit of sugar. So in that sense, we've only experienced actually with analyzing those two types that we have seen. There's many other types. They may present in other forms, they may present, in other substances. We don't know yet. We haven't found them in other substances, but we are concerned for other user groups who obviously don't have an opiate tolerance, but other methods may work. So really it's a learning experience for all of us, because this is really new to Europe, and a lot of these substances are appearing in Europe for the very first time. So that's why collating, sharing, developing networks is really important. So we learn on the go. We may learn other things as we go on. That's what we have to kind of move with, I think, and in terms of testing strips, in terms of the methods, in terms of what's available. So it's a really important time for gathering data and sharing data and being really transparent amongst our service users and ourselves. So that's I suppose we've had to look at the more expensive, unfortunately, methods that we didn't have, but we had to collaborate to use very quickly.
Thank you for that, Nikki. And I suppose we're moving in that direction now in Belfast, because in our pharmacy department at Queen's, we have the FTIR in situ, and we also have the HPLC, which, as far as we know, it can detect very small amounts of nitazenes within other drugs and other compounds. So, and we will be, okay, that's fine. Anybody else want to come in with their opinions on that from a Northern Ireland perspective, or indeed across the UK?
Maybe just if I say two things on that briefly.
Yes.
One is to say, I mean, I absolutely agree with Buff and Gary and Derek in terms of the need for rapid testing. That's there's no argument against that whatsoever. And we just heard from Nikki, it takes resource, time, and planning. I suppose the thing I would want to say is a real thank you though to our PSNI colleagues and our forensic colleagues, because in the experiences we've had over the past year, when there has been concerns and we've managed to get a hold of a substance, we've been able to rapidly test that substance with Forensic Service Northern Ireland. So while it's not a 24-hour or 48-hour turnaround time, it's within a number of days to a week. So I think it would be remiss for us not to acknowledge that is there in the first instance. But again, if we can do something around having that sped up, that would be ideal. The second point I would make, which is also really, really difficult, even when you have all the bells and whistles of the testing process, is actually getting access to the substance. And we've seen that as a real issue then locally, where people are using it and they've used all of it, what they have, or they're flushing it or something else. And there is sometimes a fear and anxiety around, well, if I have any of this and I hand it over, what might then happen as a repercussion of that? So there is a real need to engage with police colleagues around the law enforcement aspect versus the harm reduction piece. And my experience, our policing colleagues are generally very well versed in that locally, so that they don't perceive that to be a barrier. So I think it's just important to highlight those positive things as well.
Absolutely, and the service that's provided by CPARC and Forensics has been fantastic up to now, and we will continue to use that and use the services of Wednos. But I suppose we're always looking for other ways to increase that time from getting the drug to getting the answer back again. So, and it's all about collaboration. So thanks for raising that, Kevin. Yeah, Nikki.
Sorry, and just to also mention, I know it can take time to get the substance and develop trust, and that can be difficult. I think it is important to note and to consider the value of syringe analysis. So if you have someone who has overdosed and you think it's concerning, if that method has been developed, they flush the syringe with methanol, and we have been able to detect nitazenes. So that means the person isn't surrendering their substances. You remove, the moving of controlled substances, and the issues there has been valuable. We've also looked at baggies, the remainder of substances, and we've been able to look at caps and syringe caps, and just, I probably missed it in my presentation trying to get everything in. Our client group noticed that the caps, it was burning differently, it was burning more like jelly, and they were saying there was they felt that the color was different on their caps. So we were able to analyze some of those caps and to try and use the residue. So really kind of thinking out of the box in any way you can get some of that substance, to keep that in mind, and for the labs to be able to have a look at. But I think the importance of syringe analysis has been a really excellent tool as well. And with the bloods that we've got, it has been very helpful in terms of people who have presented to hospitals, but it was far too slow for us. The results were a couple of weeks later. So I suppose the substance, the paraphernalia, and that kind of approach was giving us the results in a few hours. So we were able to react much quicker and respond, I suppose.
Can I come in, Anne?
Yes, please, Steve. Thank you, Nikki. Yes.
I mean, we also need to end the criminalisation of possession of small amounts of drugs urgently, because it's a key barrier to access to services, as has been mentioned by Kevin and others. People are wary of using services if they're fearful of arrest and confiscation, prosecution. It's not a controversial position anymore. It's advocated by the entire UN system, including the World Health Organization, the UN Office on Drugs and Crime, the Royal Society for Public Health, the British Medical Association, the Advisory Council on the Misuse of Drugs, set up under the ACMD. I think you're on it. You're on it, aren't you, Anne? We shouldn't be criminalising people for possession anymore, because it's a massive obstacle. It feels stigma, and it's an obstacle to services. So a lot of these other things that we've been talking about would be enabled if we weren't still trying to arrest, prosecute, and incarcerate the people, the vulnerable populations that we're also nominally trying to support and help. So that, I think it's a fundamental principle that we shouldn't be criminalising vulnerability, poverty, and substance use disorder.
Absolutely.
But we do. So that needs to change as well, urgently.
Absolutely. I suppose the other thing in relation to that as well, from a UK perspective, and Nikki, it's different obviously in different jurisdictions, but we also have to go through quite a rigorous process to gain a home office license for Schedule 1 drugs, and that takes a long period of time. It just so happens that fortunately at Queen's we have that, so there's huge barriers to research and practice that the government needs to look at. Whether we see that in the next few years, I'm not quite sure, but we're keeping the conversation going. Does anybody else want to come in?
And I think you can
Yes.
call it, David. Yeah, okay, thank you. Well, look, I think that the amount of conversation there's been on the chat is phenomenal, and I think it showed first testimony to the interest there is in this subject and the contributions that we had this morning. I think that there's been a fantastic set of contributions and discussion that's taken place, very, very relevant and key issues, and a lot of food for thought as well. So before we close, I just want to take this opportunity to thank all of our speakers today for making an excellent webinar, and just thank you very much for that. For the people who have attended, thank you for coming. Whenever we close, you will be able to complete, or then we'll get an email asking to complete an evaluation. I'll really appeal for you to do that, so we can find out how your experience was in this, but also because we're still planning what our future webinars are going to be, and we'd like to hear from you around what subjects you think that we should be focusing in on. So it'd be good to get your input around that. So thank you everybody for attending, and that's us for the day. Enjoy your weekend.
Thank you.
Thanks a lot. Bye-bye.
Thanks. Thank you so much, Gary. Thanks, everybody.